Nick Cooper. I'm the chairman and president of the Atlanta chapter. We have a very special event tonight featuring our panel of healthcare experts to discuss how to bring free markets back to the healthcare industry. So I'll just kind of go right on down the line here, introducing our speakers. So starting out, we have Ms. Rituparna Basu. She's an analyst at the Ayn Rand Institute. She specializes in the application of Rand's ethics of rational egoism to public policy issues. She does her research and writing focus on healthcare policy. Her work has appeared in Forbes.com, Politics.topics.com, Townhall, and the Daily Caller. She has been interviewed by radio programs all across the nation, including NPR, and frequently speaks on college campuses and other venues. She graduated with distinction from the Schreier Honors College of Penn State University with a bachelor's degree in biology. And she is an alumna of ARI's Objectivist Academic Center. In the middle, we have Dr. Shabir Bambat. He is the co-founder and chairman and chief technology officer of LumaMed, which is a medical device company. He has over 17 years of experience in developing innovative medical devices, intellectual property development, and regulatory strategy and clinical trials. He has a PhD in chemical engineering from the University of Pittsburgh, and he is an expert in the field of spectroscopy and biophotonics. It took me a second to learn how that was pronounced the first time I read it. So. He co-founded Guided Therapeutics, which is a company developing a non-invasive cervical cancer diagnostic product. And he also owns several patents and publications in the areas of clinical monitoring and diagnostics, and is a recipient of many NIH, that's National Institutes of Health, Small Business Innovation Research grants, totaling in excess of $6 million. And on the far end, we have Mr. Matt Jansen, MPA. He is the Chief Development Officer of Telehealth International Partnership, which is a telehealth IT company, which is sort of like what it sounds, using telecommunications for diagnosing your health. He has over 15 years of experience in public-private enterprise, strategic planning, and development in the IT space. He has designed local, regional, state, national, and international efficient and sustainable telehealth solutions for various healthcare users. So that's like all levels that you can possibly have to interact with people anywhere across the world. He has focused on providing state-of-the-art, high-touch, quality healthcare to hundreds of thousands of patients globally. And in his past, he has established one of the largest Boys and Girls Clubs of America projects to sustain after-school programs for 5,000 members. And he implemented one of the first rural school-based health clinic model in Georgia. And also, as a side note, he also co-created a charter school that was recognized as Affiliate of the Year in 2007 and Charter School of the Year in 2008. By the communities and schools of Georgia. So a little bit of cross promo with our School Choice Week event coming up in January of next year. So we certainly appreciate all of our distinguished guests and speakers to come up. Each person's going to come up and start out with about an opening statement, and then we'll move to a moderated question and answer portion, and then we'll open it up to audience Q&A, and you guys try to come up with some good ideas, because we'll be giving away a free copy of Ayn Rand's Atlas Shrugged at the end of the evening to the person who asks the best question, in Ms. Ritu's opinion, since she is the representative from the Ayn Rand Institute. All right, and now without much further ado, please help me in welcoming Ms. Ritu Basu.
Can you guys hear me in the back? Are we good? It doesn't sound like it's on. Is it on? It's on.
It's on, but it's very thin.
Is this better or the same? Better? Okay. If you can't hear me, just let me know. my comments on, because Obamacare is a huge law, right? So I want to focus on a little portion of it, and it's how it impacts young people, how it impacts millennials in particular. I know this is an important group for AFF, and so I'm going to talk about that, how Obamacare impacts young people. If you've heard of Obamacare in the last few days, I'm betting you've heard of the comments made by the architect of Obamacare that have really come under fire. Have people heard about that? Yeah, really nice, right?
Stupid American.
Yes, you're stupid Americans, you're stupid voters. Transparency is a joke, right? It's a real political advantage, he said, to hide from the American public what's going on in Obamacare. And that he said that if people knew what was in Obamacare, they wouldn't like it very much, and the law probably wouldn't be the law of the land today. And one of the things that the architect really talked about, when he talked about, we wouldn't have had Obamacare if people knew about this, was how Obamacare really impacts young people. What Obamacare does to them, how it treats them. This is a very central part of the law, and it was certainly hidden from people when people were debating the law. So it's very, very important, I think, to be clear. So I want to start by kind of setting the context in terms of what is life like when you are a young person. And I can speak personally about this because I am a millennial. So these are millennials are in their 20s and their early 30s. That's the cohort. And life at that time, right, it's about building your life. I mean, you're done with college and you're out there in the real world, you're working, and the whole idea is to chase your dreams and to build the life that you've wanted to have. And you finally have the independence to be able to do that. So you might want to start your own business. For me, it's important to save on a down payment on a home, travel the world. I'm getting married, and that's expensive and stressful, but expensive. It's all about building your life, chasing your dreams, achieving your goals. And Obamacare is an impediment to that. I mean, make no mistake, Obamacare is an impediment to millennials in their pursuit of their happiness, of achieving their dreams and their goals in life. What Obamacare does is that it does require young people to sacrifice the pursuit of their happiness to pay for this massive new healthcare program. So Obamacare is the greatest growth of government control in almost 50 years, and it's very, very expensive, and it's the young people who have been conscripted to pay for this. And there's a lot of ways in which people are being conscripted into paying for Obamacare, but young people are a new target under Obamacare. And specifically, and you might even know people who are in this category, right? Health insurance. Health insurance costs have gone through the roof since Obamacare, particularly for young people. And this is by design. They call it rate shock, but it's not really a shock if you knew what was in the law, if they would have told us, which is that Obamacare requires insurance companies to really, really overprice health insurance policies to young, healthy people. So if you're a millennial, you should have low health insurance premiums, right? Because you're not going to get sick most likely. Just like in car insurance, if you're a safer driver, you're expected to incur lower costs, and so you're supposed to have lower insurance premiums. Obamacare says that's basically illegal. Insurance companies have to overcharge young people so that they can foot the bills of older Americans, because that's what the government has decided needs to happen. So young people are seeing their premiums double, triple, thousands of dollars more people are paying in insurance premiums, young people are paying to pay for Obamacare. And it's not an option, right? This is not an option that, oh, I don't want to buy insurance, right? We have something called the individual mandate in Obamacare, which says there's no escape. You have to buy insurance. It's illegal. You have to otherwise pay a penalty for not doing your duty. And this has real life consequences. I mean, this is not just dollars. I mean, this has real consequences for people. I know so many young people, friends even, who want to start their own businesses. Well, what do you have to do to start your own business? You need to save up to be able to do something like that. Well, if you're paying thousands of extra dollars every year to fund Obamacare, that means your goals come second. right? Your goals in life, your priorities in life come second. I want to save on a down payment on a home. That comes second. First, people like me have to pay more for health insurance to fund Obamacare. Buying a safer car, moving into a nicer neighborhood, traveling, all the goals, all the dreams that you have, Obamacare says to young people, put those seconds. You need to sacrifice that to do the government's bidding. Now, I'm an advocate of free markets in healthcare. And why I'm an advocate of free markets in healthcare, there's a lot of reasons, and we could talk about that. But one of the primary reasons, one of the key features of a free market is that nobody is sacrificed. That you can't just say, well, I'm having trouble paying for my healthcare bills. Let me go conscript someone who's just starting out in life and make them pay for it. Because that's what Obamacare is. You can't do that in a free market. Things are voluntary. People's rights are respected. Their right to pursue their own happiness is respected. I mean, that is an inalienable right. It's supposed to be in this country. But Obamacare is not the only law, but Obamacare is a huge impediment to you pursuing your own happiness. And it's really incompatible with you having an inalienable right to pursue your happiness. So that's where I want to kind of end my comments tonight, is that Obamacare impedes the ability of millennials to pursue their dreams, to pursue their happiness. And that is the key virtue of a free market, that nobody is forced to do things that they don't want to be doing. Thank you.
And now, Dr. Shabir Bambach.
Well, thank you everybody for being here tonight. I actually have a short PowerPoint I'm going to use the help of to address my comments. So I see it's up on at least, I don't know, 12 screens here, so it's hard to miss that. So again, I want to bring a slightly different perspective to the subject. Bringing healthcare back to, rather the free market back to healthcare. I come from the industry, you know, what we struggle with, what we need in order to be able to be free in the practice of healthcare. And so I want to actually take a step back and kind of talk to you about where we started. You know, what is it that got us here, and where are we? None of this information is new to you. It's, you know, you can Google this and find this. You know, healthcare is a fifth of our economy, $1.5 trillion a year, and we have a growing elderly population. That number, 65, just happens to be the magic number, not for winning the lottery, but for all kinds of diseases that will afflict our population. You know, 65 happens to be the magic number for cancer, 65 happens to be the magic number for stroke, and for complications from diabetes and various other diseases. And that population is increasing rapidly in this country. Not just in this country, but in the rest of the world as well. And then in order to deal with that population, here's another one, we have a doctor shortage. And that's mainly because of the fact that Congress has limited the number of graduate medical education that goes on, that doctors have to do after they get their primary degree. The urbanization of medical practice, you know, Matt is going to speak after me, and he's going to talk to you about, you know, the need, for example, for telemedicine, because we don't have enough doctors in rural areas. Specialists are flocking to fee-for-service practices. Nobody wants to be a primary care physician. Everybody wants to be an anesthesiologist or a pathologist, where you can charge a fee for the service you provide. And then, of course, there is this attrition. I don't know about you, but every other doctor I speak to, they complain about the fact that it's no longer fun being a doctor. And so those are issues that are causing this doctor shortage. And then, of course, we had this large uninsured population. So here is where we are as a nation in terms of our spending on healthcare. Again, information that is easily available. We spend close to $8,000 per capita, far more than any other industrialized nation. What do we get for that money? We're actually the last in terms of the industrialized nations, in terms of the quality of healthcare we get. So that's kind of the ground. This is where we are. And so I want to talk to you about why we are here. Well, the first point is that the way medical science care is practiced in the US is quite different from, for example, how it's practiced in Europe or in the Far East. We practice defensive medicine. We are afraid of malpractice. There is this fee-for-service model that is so prevalent in our healthcare DNA here. The doctor, you come to the doctor, you're a commodity, you come in with an affliction, that symptom is treated, you go home, you come back the next day, the whole process starts all over again. And so that continuum is largely absent. And that's basically what care coordination is all about. So many times, and I like to say this, oftentimes the primary care physician finds out from the wife of his patient that his patient died yesterday. That's not the way it's supposed to be. The primary care physician needs to know this. The third-party payment system. We don't, until very recently, we weren't paying for our health care directly. This concept of the Centers for Medical, CMS paying or a third-party insurance company paying is so prevalent here, not necessarily in the rest of the world. So the dominance of payers, the health insurance companies dictate how much the doctor gets paid. And then, of course, with all of that comes the cost of bureaucracy and payment delays. If you ask any doctor, how much money do you get of the $1 that is owed to him? The number that is often quoted is 18 cents. 18 cents of the dollar comes back to the doctor at the end of the day. And so it's a huge disincentive for physicians to give the kind of service that they would like to give their patients. We would like to believe that by and large, most doctors want to do the right thing. I've talked about the aging population, but I wanted to point out that we are, as a country, unique in the sense that the prevalence of chronic disease, which is about 80% of healthcare costs in this country, is huge in huge in the United States. And for example, Japan, they have more longevity than we do, and the chronic disease level is significantly lower than what we have here. And that is, of course, a big financial sink. And then coming back to from a medical device, a medical business, we have these bottlenecks to innovation. We have perhaps the most advanced engine, if you will, for innovation in this country in the area of healthcare. But we have a very burdensome regulatory process. We have to deal with the FDA, we have to deal with the Centers for Medical, CMS, we have to deal with a lot of the bureaucracy in order to get a new technology approved. In fact, because of that, a lot of companies will launch their products in Europe or elsewhere several years before that product becomes available in the United States. You all heard about the medical device tax, for example, the 3.5% tax. That is a huge disincentive, if you will. You don't tax medical, you tax cigarettes, you tax bad behavior, you don't tax life-saving innovation. So that's a big disincentive for us. And then all of that is leading us to a loss of American dominance. You probably heard about inversion. A lot of the larger companies are now going overseas and just not just to avoid all of these issues, but also to avoid the taxation. So, I touched upon US life expectancy. These are some charts that I have. The cost of a long life in the United States is significant. And that's not because, we're clearly living longer. We aren't. But even that little bit of life that we have beyond the 65, we're paying a huge price for that. So I wanted to talk a little bit about, and I know that this is a controversial issue with the ACA, aka Obamacare. 40 million people are gradually coming into the healthcare, in the insured fold, if you will. And it's not like we're not taking care of them right now. We are. That money is already getting spent, but it's not getting spent in the earlier instances where the disease is easy to cure or where the cost is lower. We're actually spending that more as when the disease becomes a crisis. And so a lot of that money is actually being spent in hospital-based care, for example, instead of in private practice. And so if that money can be somehow spent earlier in the care continuum, we are going to save a lot of money. So what does the Affordable Care Act, or Obamacare, what does it do and what does it not address? So here is the do's and the doesn't. So it reduces the number of uninsured, a good thing, because that money is being spent wastefully, and 80% of those people are working families. It encourages the use of technology, EMRs and EHRs, electronic health records. You probably heard about that. It spawned this whole industry of health IT, particularly in this town in Atlanta. And this concept of meaningful use, meaning use of this technology in a way to address and provide better care. And then, of course, it's affecting the way doctors are practicing medicine. We're moving slowly, gradually, from this fee-for-service model to what is called pay-for-performance, meaning the doctor actually has to care about what happens to you over the progression of the disease or until it leads to a cure. And it's not, every time you come in, it's not a ka-ching every time. This concept of capitation, the doctor gets paid for a one-time fee no matter how many iterations it takes. And then the reduction in rehospitalization. Hospitals are getting penalized if the person gets readmitted in 30 days. And then, of course, this cost harmonization and transparency. Healthcare is the one area where you don't know how much you're paying for the service. Every other aspect of your life, you know pretty much beforehand how much you pay. And so that is changing. What is not changing, unfortunately, is this idea of this third-party payment system. And so that's something that we would like to see. There is a higher out-of-pocket cost component with this, but that's not changing fast enough. Malpractice burden is not changing. The regulatory burdens are not changing. And this whole concept of population health care and care coordination is not happening fast enough. And that's an area that we would like to see some change. And so I just wanted to end with this. I don't know, but it's in my lifetime, I remember that there was a time when the doctor could do it all. The doctor could come to your house, diagnose a condition, treat it, and collect a payment. The population grew, medical knowledge exploded, and then we had specialization. What happened? The simple became complicated. And then we ended up with a fractured system, lots of moving parts, all in individual boxes and silos. The left hand doesn't know what the right hand is doing. And so the business of medicine morphed into the business of business of business. And that's the issue that is happening. We need to go back in order to have a free market. We need to go back to putting the patient first. Thank you.
And our next speaker, Mr. Matt Jansen.
I feel like a comedian up here with the light and the dark bar and beer in my hand. Can I stand?
You want that move closer?
Move closer? Okay. Yeah, this works, kind of. I'll work on it. That's good. I'll just hold it. Well, I want to thank everybody for the opportunity to come and talk to you a little bit about what what's going on in my world, because it seems like we're all the center of our own universe a lot of times. We have to kind of think outside of ourselves a lot of times, and it's hard to do that. I just got back from China about 2 weeks ago, and I'm still recovering a little bit from that exposure to a totally different culture with a really unique set of things going on around the healthcare space. A lot of the things that we've talked about tonight, I work on a day-to-day basis with here in Georgia, but to really understand what we're going through here in the U.S., state by state has different laws, different rules around different types of medical, healthcare spaces and policies, procedures, and all that. But when you go outside of the U.S. And you expose yourself to other cultures, it gives you a little bit more of a perspective. I find it to be very useful. We have an office in Zambia, Central South Africa, where we're also doing some work with the local government there, which is a military-based government. So when I went over to China, I went to Beijing. I landed in Beijing. I don't know if you know the population statistics in China, but there's about 1.4 billion people in China. When I landed in Beijing, there's about 24 million people in Beijing. I took a train, which was like taking a train from here to Valdosta, Georgia, which is on the Florida line. It's about 3-hour train ride, 3-hour drive to a city called Tianjin. And there was 15 million people when I got off the train. Spent a little bit of time there. There's a big medical community popping up, some private hospitals, first of their kind in China, or the second try of their kind in China under their government there. And then I took another train, about another half hour, which is like driving over to, say, Tallahassee. And there was about 10 million people there. That's a very rural community in China. So I kind of use that in a perspective of population health management. And the population health management in China is snowballing. So you think we have issues here. With 10,000 people a day turning 65 years of age in our country, we have to do business differently. We have to change our perspectives. We have to change our policy. We have to change somehow, some way, how healthcare is diagnosed closer to the patient. And preventative medicine can take place closer to the patient. Patients don't get well in hospitals. The really, really sick need to be in hospitals, and they need to be in under doctor's care continuously. Patients that can be monitored, patients that have chronic illnesses that can be monitored in a very efficient, a very effective way right out of their homes. And believe it or not, 75–80% of your healthcare does not come from the healthcare system. It comes from your caregivers. It comes from the people around you every day. So we need to empower them. We need to empower the people in your social circle, the people who take care of you, the people you take care of. So there is a really unique opportunity for us. And I'm in this space every day. I get to work with a lot of cool toys and get a lot of devices thrown at me. I get a lot of really neat things that our healthcare system just can't adapt to. They can't adopt quick enough. Policy that really hinders some of the innovation within healthcare is very prevalent. I see it every day. I see it, especially when I'm working with patients. I work in very remote areas of Georgia, and some of our health disparities here in Georgia are on par with the same health disparities that are in Zambia, South Central Africa. We have over 80 communities here in Georgia that don't have access to a general pediatrician. We have over 60 that don't have access to a general practitioner. That is the basic fundamental foundation to a patient-centered medical home. That is having access to someone with a base knowledge, not a super subspecialist like an endocrinologist or a pulmonologist, but someone who can basically understand your biology and how it works in relation to you. Some of the things we also have to become a little bit more familiar with, and this is me working with physicians. Are there physicians in the room? Because I'm talking about you, and I don't want you to get upset, but we have to work with physicians, patients, us. We have to work with physicians in understanding us, because our biology, if you were to look at us the way physicians do, they look at us on a mean. They look at us on a standardization scale based on my age, based on certain conditions I've had, or maybe I have a condition. So they kind of lump me together. That's how they that's how they, kind of process data. It's just how anybody would do it. That's how computers do it. But until I become more individualized, before I can track my data a little bit more in my own time and provide that access to my physician group, because I'm usually working with a physician group when I'm working with patients. There's rarely one physician in charge of that one patient. There's usually, with a chronically ill patient, there's usually at least anywhere from 3 to 5 physicians continuously working on that patient over the course of several months, if not years. And like stated earlier, they work in very siloed environments. They don't communicate well. And our first stab at trying to get everybody to communicate well together was electronic medical records. Taking all the paper out there and shoving it into a database system. Then they created different database systems that were siloed. Then they created this thing called meaningful use that you're hearing about, where one database system has to communicate with another database system through a series of HL7 and CCDA form. I won't get into all that, but it's real crazy technical crap that has to go on between databases so they can share information. Your information that you should be in control of. So it's kind of, we've created more and more of the same problems. We have some new rules to play by to a certain degree at the federal level. State level, each state composite board or medical director, state medical board acts a little differently towards their different schools of medicine and how they interact with each other. I don't know if any of you have ever sat in on any of the state medical board meetings here at the CAP or in Atlanta. Very interesting, because they usually are arguing over how many nurse practitioners to physicians can be monitored. Things like that. Stuff that, it's not really important. State medical boards are very archaic. They're not really up to date with the latest information or technologies that are available. So I have a really fun job of having to educate continuously on things that have been around for over 35 years. What I do in our space today with some of the new video conferencing suites and some of these new cool peripheral toys where I can stream heart and lung sounds from one side of the planet to the other. I can share your images from your CT scan to a cloud, and that cloud can fire it off to 15 neurologists all at the same time. They can all look at it, give their opinion, and shoot it back. All that stuff has been around for 30 plus years in our country. It's not new, which is kind of surprising to people. Some people think what I do is really new and cutting edge. It's almost scary to think of what I do was being done 35, 40 years ago. One of my board members, Dr. Jay Sanders, he's out of Johns Hopkins, was doing this with one of his professors 35 years ago with closed circuit televisions, streaming live surgeries from one side of the US to the other, physicians sharing consults with each other based on patients, demographics and data. This is not something new. When you walk into a patient's, to an exam room, or you walk into a patient's bedside in a hospital, what you're looking at is telemetry equipment. Hence the word telemetry. That patient data is remotely being driven from that patient to that machine, which is being diagnostically reviewed by a physician remotely, even though they're standing in the room. They're not pulling that data off of you directly. They're not putting their hands on you as much anymore, as you probably noticed. That's just the standard of kind of having a high efficiency rate in order to get paid better. So yes, our system needed a reboot. And I asked one of our university systems here a couple weeks ago at another event, I said, if you had the opportunity, he runs a medical institution here, if you had a chance to reboot the healthcare system, what would you do? He said, well, I would make it patient-centered. I think that coming from a university system physician, someone who's educating our new and upcoming physicians, which we're not producing a whole lot of to really meet the demand out there. it was his comment that really stuck to me, that if you don't think it's patient-centered, then what is it? Right now, what's driving the industry is payment. That's not a bad thing, because you want to be paid for a service that you deliver. You don't give things away. That's not how it works. But if you're giving away bad service, if that service isn't supported, isn't standardized, then it becomes a hodgepodge of opinions. So we do have to create standardization. We do have to create a new model. We do have to create a new way of communication between physician groups and allow for it to happen more fluidly in easier ways so they can be reimbursed and they can make a living. Right now you're seeing a huge change in physician practices. They're going away. If you haven't noticed, a lot of our physician practices are being bought up by hospitals, big major hospitals. There's a lot of hospital closures in Georgia. I don't know if you've noticed that. But if you're a small physician practice, you cannot survive in this climate. So we've got to change. We've got to change that. We want the local physician to be empowered. We want the local physician groups to have access to larger population groups in order to manage them. But they're going to have to change. They're going to have to adapt to some of these new techniques and technologies. So with that, I know where I am on time. I'm all right? I'm good? Another minute? Well, with that, I don't want to overcook the ham in relation to what I feel is the focus of the ACA or what it's not focused on. But when I started doing this, roughly about 10 years ago in a small rural community, right when, well, I wouldn't say 10 years, about 8 years ago, when the ACA, that first term Obamacare came out, when I was in a rural community in South Georgia trying to launch a school-based health center where I was connecting physicians from Children's Healthcare of Atlanta into a small rural community in South Georgia. And this was something that they had never heard of. I was really concerned that I wasn't going to be able to bring care into a community. So we really, my community rallied around this, and they said, listen, who cares about all this noise out there? Who cares about some of these policies that are being drafted? And of course now there's some law in place and we're still sifting through what it means. But they said this is our chance to make a decision. This was our chance to change the way we felt healthcare could be delivered locally. I had a large population of kids that had diabetes and were asthmatic, that did not have access to pulmonologists, did not have access to endocrinologists. Now they do. Their life trajectory has changed. They're going to be productive citizens. The whole community will have a longer, more successful opportunity at sticking together as opposed to their kids leaving when they get older. So that's what it's about. That's what it's about. It's about bringing healthcare and the market back to the local community for me. It starts there, it will always end there. Big cities are great. They're small communities within this big old city of ours right here. I live here. And you go to those local communities, that's where it's got to happen. So I really commend you guys for getting together, because this is what it's all about. It's about small communities getting together and making a difference any way you can for the people around you. And that's all I got. Thank you.
All right, we have some time for Q&A. Go ahead.
I'm just gonna knock this out right up.
Okay, first, is this for a specific speaker?
Actually, for the panel.
For the panel.
Get the standard of lights too if you're gonna ask them.
That's right, yeah. Stand in the spotlight if you're gonna ask a question. I did it my way.
Oh, it's not karaoke? All right, real quick, we have an opportunity now because we just took over full Congress, at least more of the conservative side. I know we're not all Republicans, but we're more libertarian conservatives. My only question is, are we looking to fully repeal Obamacare? Is that our goal right now, to just completely get rid of that program and start something new? What's your thought on that?
Who's to go first?
Good question. I mean, I don't speak on behalf of the Republican Party or anything like that. So, I mean, I have some insight into what I heard that they want to do, since I'm privy to some of those conversations. And as far as I know, they don't want to fully repeal it right now because there's a lot of moving parts. As you may know, the Supreme Court is reconsidering Obamacare, and they will rule on that in June. And so I don't think you're going to see a lot of bills coming forward right now during this period to repeal Obamacare fully. There are certain provisions that they're going to work on to try to get rid of those. But the other question should be, okay, we don't like Obamacare. What the heck do we want to replace it with? And frankly, the Republicans have been very, very disappointing in this regard, because their solutions are basically Obamacare light, Obamacare copycats. And I think the American people can see that. We went through a lot of trouble to get Obamacare passed. It was a lot of work, and I don't think anybody wants to go through that again if all you're going to do is try to do the same thing in just in a different way. And when I say doing the same thing, I mean it's the same goal. Obamacare's goal was to give essentially free or mostly free subsidized health care to Americans who did not have it. And there's a lot of reasons why they did not have it, and we can go into that. But that was the goal. The goal is to move towards universal coverage, which really is a euphemism for socialized medicine. That's the path we've been moving for the last 100 years. Republicans want the exact same thing. Same goal, different means. That does not get anybody motivated to really undo Obamacare, and that is the challenge I think Republicans are going to definitely face if they even get into that area where they're given, the option of coming, really trying to push through their own alternative.
I agree. I think that's, there's too much work that's been done to turn the clock back and take all of that away. I think there's, for all of its faults, that it is a start, and it has gotten us somewhere. There's a whole industry that has been spawned because of Obamacare, particularly in electronic health records and stuff like that. So I think there will be aspects of that will be changed, perhaps repealed, replaced.
So are we looking at like a line item?
Probably, more like a line item.
Medical device tax.
Exactly, thank you. So the medical device tax, for example.
Like a line item repeal.
Correct.
And then the record keeping, which is probably a good thing, keep some of these things. So you're talking about a line item.
Absolutely.
Well, there's a seismic shift in relation to how physicians are going to be paid and reimbursed for your care. And we touched on that a little bit. Seismic shift. That means the satisfaction surveys are going to play a big role in how they're scored. Hospitals are already getting dinged for readmissions. Orlando Health, anybody from Orlando? They paid over $300 million in fines last year in relation to readmission. That means a patient who was discharged was readmitted within 30 days. You're seeing that major shift right now. Those are just some of the things that have happened that I think are waking them up a little bit, changing the system. I'm not saying it's going to work, but there won't be, the ship is already sailing. We're going to have to start to adapt some changes as we move, but it is going to be a mountain of changes.
All right, so one last point. So in a professional opinion, from your professional opinion, there is no hope to actually repeal the whole thing.
No.
Thank you.
You seem to have consensus on that.
I mean, who wants to really repeal Obamacare? It's a real question. People say they want to repeal Obamacare, but you go into the fundamental provisions of the law and everybody likes the fundamental provisions. Everyone wants to force insurance companies to give coverage to everyone, even if you have a pre-existing condition. While that's a basic provision of Obamacare, unless you're going to challenge that, and Republicans aren't willing to challenge that, you're not going to, there's no point to repealing Obamacare. Stick with what you've got. I mean, there's no real benefit to doing anything differently. And just to be clear, I think we should be moving towards freedom. I think we should be moving towards the free market. But you're not going to get that unless you challenge the goal of Obamacare, which is universal coverage. And universal coverage is completely incompatible with free markets. That's not what you get in a free market.
All right, and another question?
Yeah, I have a question. Well, a comment is, well, actually, I don't think you should discourage the people like that. You know, give people 5 years, and I guarantee there's going to be a lot more people who are going to want to get rid of Obamacare entirely. I'm a military veteran. You know what helped morph me into a staunch advocate of the free market? Seeing the VA. And I think people over time are going to recognize that the only way to ensure quality is through something called having to meet a profit and loss test on the free market. And I think where some of the panelists, I think where some of you guys fail in the message that you're delivering is when you talk about making the system patient-centered, I mean, that's a platitude. I think we need to stop sugarcoating this. Okay, let's go back to, in fact, there's a great author by the name of Morris Beal who wrote a book called Medical Mussolini. And if you go back to, especially under Roosevelt, the economy was cartelized, living under Fed for several decades. You know, and I think that, you know, that's why people don't understand what the real solution is. They look at it like, under Bush, we had a free market. You have Obamacare. That didn't just, you know, fall out of the sky. The system before them was
Do you
failing.
have a specific question that?
Well, yeah. What concrete answers would you guys give? Because, you know, I can think of a few right now. I would say abolish the FDA for one. Okay. How about repealing medical licensing laws? I haven't heard anything about solutions. I mean, the government doesn't sustain itself by satisfying consumer demands, i.e., earning its income. And that's the message we need to get across. We need a real free market.
Okay, and your reactions?
Well, first I want to thank, you know, my dad's a vet, my sister's a vet, so I fit kind of the profile of a kid who grew up with a military family. A lot of folks in my family are benefactors of the VA, depending on how you look at it. So, you know, I work with the VA on some strategies right now, working on some ways that we can better serve our vets that are coming home and our vets that have been home and need care. So I'm not saying there's a one-size-fits-all model here. I've been, like I said, I travel a lot as part of my job, so I get to see unregulated areas. I get to see countries where there's no regulation, there's no FDA. I'm not saying that FDA is perfect. It's got a long way to go before it becomes anything close to perfect. It's got a lot of problems. But when people look at standardization across the board when it comes to medical care, one of the things that we have to be concerned about here in the US is people are coming here for Western medicine. People are paying high dollar price to come here. And to receive care from our physicians, you're seeing physicians go into concierge-based only medicine now. That means they are going from 3,000 to 300 patients. And they're going to charge you for that. But they're also outsourcing their knowledge to other countries. Believe me, this is happening at a very rapid rate. This is not something that's going to slow down anytime soon. It's a way for a physician to practice medicine, and that's really what they want to do. In our patients, and I don't want to say, when I say patient-centered, I mean we have to be focused on whether or not the patient is at the center of the equation, not the insurance company, not how you get paid, not the treatment plan that has been suggested based on a decapitated rate of what will be covered over the next 3 to 5 years if you live that long. That's how decisions are made today. We've got to change that. And I said there's no magic bullet here. We've got to continue to try. We've got to continue to innovate.
So, sorry, I can't see the gentleman where he was going to ask the question. Oh, hi. It's really bright. In terms of some steps moving forward, I agree with you, FDA needs to go. I don't think that can happen anytime soon, unfortunately, though it's one of the biggest monstrous injustice ever. We could talk about that if you have questions about that. But in terms of Obamacare, I mean, the fact that healthcare in the United States is ridiculously expensive, that prices keep increasing, that prices don't even make any sense. You got one insurance, you know, a hip surgery costs this much, you're uninsured, it costs thousands of times more. I mean, those sorts of issues, we don't have a free market. We have government control. So what are the government controls that we need to be removing to get back to a free market so we have a little bit of rationality in the marketplace? Insurance has been, health insurance is one of the most controlled industries in America, and it was that way before Obamacare. And so you need to start freeing the health insurance market. You need to start letting insurance companies actually do insurance. What you're sold today through your health insurance company, if you get it through your employer, if you get it on the individual market, those are not insurance policies, not in the sense of, they're not doing a lot of risk assessment on your policies. Health insurance these days is basically just a giant redistribution scheme engineered by the government, where you get sick, healthy people subsidize you. When you're healthy, you subsidize other people. That is not how insurance works. So you need to free the insurance market. That's the main thing. And then we have to deal with the elephant in the room, which is Medicare. Medicare is single-handedly the biggest cost driver in the United States. It has inflated prices in healthcare ever since the day it started. And by itself, of course, it's very, very expensive. So you have to do something about that. And ultimately, you need to abolish Medicare. That will get you to a much better healthcare system much faster.
On that note, actually, I was going to personally ask a question with regards to Medicare, Medicaid, and you know, obviously Social Security is the other big, social program that the government has on the federal level, at least. What would be some of your reactions to what Ritu just said, you know, in regards to abolishing Medicare? We also have Medicaid out there, of course. Nowadays, that's, you know, call it the third rail, we call it the fourth rail, the impossible rail of politics. You know, obviously, it's going to be politically difficult to ever pass something like that on through. But you know, what are some of your reactions to specifically Dr. Bambot and Mr. Jansen to the quip about Medicare?
So in the United States, Medicare pays for CMS, Medicare and Medicaid. It's about 20% of the healthcare costs. It's not the biggest driver, but it sets the prices. That's where all of the the benchmarking is done, and the rest of the health insurance companies basically tend to follow suit. I don't know what the genesis of Medicare or Medicaid is. Maybe it is what it is. It was a social program, but that whole system has to be reformed. I think, despite its size, Obamacare as a law is working in the realm of an environment where you have these other institutions. You have FDA, you have CMS. It's basically what it tries to do, and it's a very controversial thing, obviously, but it's trying to work with that system. If you want a more perfect system, then you have to go back all the way and start from scratch. You have to talk about FDA, you have to talk about CMS, you have to talk about all of these other institutions that have taken years to put together and think about working. And that, I don't think anybody has the appetite to deal with that right now.
I do. Me too. Yeah.
I mean, it's not about appetite, it's about setting goals.
It's setting goals.
And you have to have a goal of freedom to move towards freedom. You can't abolish Medicare overnight, but that has to be your goal. And right now, that's not the goal. Right now, people are saying expand Medicare, expand Medicaid. I mean, Medicaid is bankrupting state governments. What does Obamacare do? It massively expands Medicaid. I mean, I feel very bad for people who are on Medicaid. It was already hard enough to find a doctor willing to treat you before Obamacare if you're on Medicaid. Little children can't get health care who are on Medicaid, and Obamacare expands it, makes it more difficult. So one thing is for certain, Obamacare is not a law that is very particularly concerned with individual patients, with individual health care. It's all about collectivism. It's all about the collective. It's what's good for the group, and some people will suffer as a result of that, but that's the goal, and that's the problem.
Yeah, a quick comment actually in response to that is that economists tend to talk about the world of second best, and it means that given the fact that we can't ever take it to can't commit a nirvana fallacy and say because it's not perfect we can't settle for whatever the proposed solution would be. We live in a world of second best right now that, no matter what we try to do, I think, and I think some of our panelists might agree when we say that whatever sort of changes we're trying to push or trying to effect into action is going to be incremental in whatever sort of areas. We have about time for maybe one or two more quick questions. Anyone else? All right. Come on up.
Okay, what do you think about Walmart and physicians there? I go to Walmart for my eye care. I can go anywhere I want for eye care, but I'm going to Walmart, and if there's a physician available to me at Walmart, the market is taking care of it, I'm going there. I'll give you $40. I'll give you whatever the going rate is. How is that going to affect it, and who else is going to do this? Because somebody's going to step into the breach. What's going to happen?
So you can go to the doctor at Walmart and get a 40-ounce tub of mayonnaise afterward. Go ahead.
I think it's a great idea. I think that freedom to be able to go to any doctor of your choice, doc, take care of me, and here is your fee. That is the nirvana. That is the ideal. And that, I can see that the audience obviously wants to talk about, revamping CMS, revamping FDA, all of that. But this whole system of third-party payment has detached the payer, the customer from the service provider. That relationship was lost many years ago, and we need to get back to that. And that's basically what the Walmart model to some extent is doing.
Who else is going to do that?
Well,
I go to Walmart too for my eye care, so I'm right with you on that. I think it's great that these kinds of things are happening. Here's the real issue though. They're happening because there's a lack of regulation. And that's what people need to realize, that a lot of places you can't get these sorts of things. So one of the things that the CVS and the Walmarts, they try to staff these nurse practitioners. So they don't have doctors, they have nurse practitioners. In a lot of states, it's illegal. It's illegal to go to a nurse practitioner and get treated. You have to go to a doctor. And so there's all sorts of regulations in place that are preventing the Walmarts, preventing the CVSs, preventing all these people from delivering good care that people obviously are willing to pay for. And that's what's really concerning, that this is all kind of like bootleg in a sense. And that's exactly what you see in other countries as well. Like you see in Canada, private medicine is clearly better. They have socialized medicine there. It's just private medicine when the regulators aren't looking. And that's what's really concerning, that what's going to happen tomorrow if somebody turns around, the government says, wait a minute, we didn't sanction this, and that's a real threat.
I like the bootleg. Flying under the radar.
Yeah, hybrid bootleg, yeah. Walmart has deployed over 2,000 physicians now in their network. They started a new pilot, so a doctor will be coming to Walmart soon. The only thing that you want to make sure, Walgreens, CVS, everybody's stepping up their game. Nurse practitioners are now consulting or are going to be presenting you to, say, a physician. 80% of our healthcare costs are embedded within chronic care, not just primary care. So it's great. I go to the CVS too. What we don't want is for the chronically ill patient to think that Walmart's going to replace their endocrinologist and their pulmonologist, because you still have to have some continuity and coordination of your health care. So if you get a prescription from a Walmart physician, that prescription goes into your health record. That health record should be able to be, if you go to a local hospital, or if you're, say, get sick from, say, that medication that was dispersed to you or given to you, then there's a record of it somewhere. So if you end up in a ski resort in Aspen and you get hit by a ski lift, they have a record of that somewhere, that they don't treat you for something and cause some sort of reverse type of problem to happen, or adverse problem to happen. So that's part of the thing that we have to make sure that we don't cut out the local physician either, because they're having a hard time staying afloat, but getting into their waiting rooms is very, very difficult. Sometimes you wait 2 to 3 hours for a primary care visit. So as long as Walmart doesn't cut out the local physicians and they integrate with local physicians, with local physician groups, whether they're specialists or pediatric specialists, especially around our kids, we're going to want to take our kid to a place where they can get seen quickly and maybe not be as exposed if at all possible. However, a lot of us want to go to a pediatrician in relation to our kids. Walmart might not be that. So there will be options. I work with a lot of them. I work with physicians who work out of their homes 24/7, who can provide care all over the U.S., all over Georgia right now. They can provide care in very efficient ways to their patients like you're describing. But we're going to see lots and lots of models like this coming, and so you will have that option, I think, coming very, very soon. But we want to make sure that the standard of care is met. It's not a phone call. If you do not have an established patient-physician relationship, there's a hard time describing what a sore throat is over the phone. In a temperature, and say you have tonsillitis or you have strep throat, you can't diagnose some of these things without certain types of peripheral devices and tests that have to be done, lab work. So we can't think that this is going to replace or supplement what the true elephant in the room is, which is chronic care. We are living longer, but we're not living longer healthier. I can tell you that. So we've got to get better at this. And it's not one chronic illness. It's usually comorbidities. You're managing 2 or 3 illnesses when you're talking to a diabetic patient who also has congestive heart failure and also is going under treatment, hypertension. So you're dealing with multiple issues with certain patients that can't be taken care of at Walmart. So, and that's 80% of our healthcare market right now. So the bigger elephant in the room is not that Walmart shouldn't provide you care. It's how do we work with our patients who are in need of more care closer to home. That's my.
And I think with that, we are going to conclude this great panel event. Let's have everyone give our panelists a big hand.